Thank you, Baron. Not least because they've just joined us. Can I ask if our two new panellists would like to comment on this? Chand, I see you're volunteering. Andrew, I don't know if you want me to volunteer you or not. But in terms of the general issues around, the market, conflicts of interest, collaboration being construed as conflicts of interest and all the rest of it. Chand, over to you.
I mean, from the perspective of the British Medical Association, we're very clear that what appears to be an ideological commitment to competition as an end in itself is going to be harmful. In fact, we heard an excellent example from Tahir of the joint working of his department with his local GPs to develop a pathway. Now, it's very explicit in the white paper. There are no mincing of words. It actually has a sentence that says that the role of monitor will be to ensure that GP commissioners do not continue referrals to incumbent providers. The any willing provider model is an imperative in the white paper, and we are concerned, yes, that GPs and local clinicians working in hospitals may not be able to work effectively together if what they're having to live with is a monitor breathing down their necks telling them they need to be introducing patients to other competitive providers. So we think actually there's no need to have a competition as an end in itself in the NHS. We actually think it will actually be unhelpful. And we heard earlier also about the tariff, which also has been very damaging in terms of the way in which GPs and hospital consultants work together, because it has developed into a sort of adversarial commissioning arrangement where there's basically competition for a sum of money rather than actually being on the same side and aligning those incentives. So really Tahir and me as a GP should really be on the same side looking after the patient. We shouldn't be on two sides of a fence and actually in competition for a sum of money called the tariff. Thank you.
Tahir, do you want to?
I mean, I really agree with the sentiment that's already been shared. My plea to you and all the organisation and the people that you represent, to just focus on the quality of the outcomes for the patient. And I think we all love the NHS. I'm here on my annual leave day, would you believe? And I went to Leicester to talk about the same thing. And I want us all to do well. But I think we have to accept that it's an amazing organisation and it can also do a lot more and a lot better than it is at the moment. And we should not accept, the levels of sort of compliance and outcomes and the variation that exist. I think there is no reason for that sort of thing to exist, because that translates into real lives, real people, real complications and so on. But the other point you make about GPs and being able to commission and all the rest of it, I mean, I think medicine is very complex. I touched upon the fact that we can do a huge amount these days. There are 6 million biomedical papers published every year. I'm not saying that everyone needs to read all of them, but there's a very substantial number that everyone, you need to. So to keep up with even the very small area of your own field is going to be very tricky. So to be a manager and this and the other, is a different function, and will need to be properly resourced. But I think we just need to take this opportunity to focus on the quality of the clinical care, and make small and large changes and strive to improve the outcome for our patients. And what I would try and get you to aspire towards is that have our patients in drug-free remission. That's what we aim for, not for them to linger along for decades on end. We should aim to try and get them to the stage where they don't need any of our interventions.
Thank you. Another related issue, although it's not the same issue because it's not just across the so-called divide between primary care, secondary care and so on, but is the question of whether GP commissioners have a conflict of interest in also, in some senses, being providers. Of course, it's not just GPs. You can look at the existing system with PCTs and say there may be a conflict of interest as long as PCTs have had a provider arm. Bluntly, PCTs might feather their own provider arm nest before they put contracts out elsewhere. There's all sorts of potential conflicts of interest, although what I would say is that, of course, the view of a conflict of interest depends on your view of the motivation of the people in the system that's running. If you believe you're in a market system and that people are following the market culture, there may be a conflict of interest. If you believe that that's either inappropriate or isn't happening, then there may actually not be a conflict of interest because you may not be in a system which generates the concept of a market conflict of interest. In other words, you may not be in a market. But Andrew, I just wondered in terms of your GP, PCT, primary-based, practice-based commissioning engagement, have you had any reflections on these matters?
Andrew first.
I think the conflict of interest point is very worrying. And one thing that I've reflected on is that the more people talk about conflict of interest, the more they're actually expressing concern about competition. Because if there was no conflict of interest, there would be no competition. And the two really go very closely together. One thing that interested me was that I think it was last week in Pulse, they were reporting that 1 in 4 GPs are presently involved in provider units, provider companies, provider arms or whatever. And they were saying this gives rise to a great deal of conflict of interest. Now, you might say that 3 out of 4 GPs are statistically in the clear because they're not the 1 in 4 that Pulse is talking about. But the problem with this, and it's a problem that I don't think will go away, is that it's the 1 in 4 who are the entrepreneurs, who are the leaders, who are people who are setting up provider companies, who were first of all setting up practice-based commissioning groups and getting on with it. And those people are always going to be the people who are in the firing line for conflict of interest. And it's very, very difficult to see how they're going to resolve the problems. The 3 out of the 4 probably really don't care very much. And I see this as a big issue, and it's going to take a lot of solving.
Okay, thank you very much. Wendy, did you?
Yes, I just wanted to say that when we had GP fund holders, although some individual fund holders did improve services for their patients at the expense of services for other GPs, patients, the evidence from that short-lived experiment was that it wasn't a very effective way of improving the services to patients. And the GP commissioning pilots with virtual budgets, I think it was a couple of weeks ago, it was reported that 10% of them were overspent in their virtual budgets. So if GPs accept this poisoned chalice of being the commissioners, they are very likely to be ending up A, rationing because of the austerity mode of this government, and B, likely to fail, in which case they'll probably be taken over by some private sector. Now, the private sector has hardly been mentioned at this conference, despite the very luxurious surroundings and their contribution in that way. But it is a real worry if this huge shake-up of the NHS takes place. And what Andrew Lansley is saying is that he wants the patient to be the focus of care, nothing done with me, to me, without me, which I understand comes from the Picker Institute. And it's the same as the GP-led health service that New Labour were talking about. And this is admirable to have the patient more able to make decisions, but I don't think it's going to happen with the structure that he has envisaged. And therefore, I think we've got to argue very strongly with our MPs and when the bill does come before Parliament, and just not go along with this thing that it's going to happen anyway. It doesn't have to happen. I mean, ought to be like the French. Yeah.
You mean that's a call to ordure instead of a call to order, is it? I recognise that I'm in a conflict of interest here. I'm both the gatekeeper, the commissioner of questions, and also the potential provider of answers. So I'm not going to say any more. I'm going to ask for the next question. And this lady, well, there's 2 ladies here, but let me take, if I may call you the lady in red.
Can she say who she is?
Please, yeah.
Can she say who she is?
Yes, of course, yes.
Well, my name's Ruth Appleton. I'm the coordinator of a refugee project, which I started myself, and I run from home, and it's purely voluntary. I don't get paid for it, but I managed to get charity to keep it running. And it is running, and it's very much needed, but we, have great difficulty sustaining it, getting charitable donations year on year. And being part of the voluntary sector, I'm working with Links, that is Camden Links, local involvement in health networks. I'm also a supporter of Keep Our NHS Public, and I'm also a governor of the Camden and Islington Foundation Mental Health Trust.